My name is Dr. Nick Harris. I am the President and CEO of iGenix Laboratory. I've been a member of iLads since the inception. I was one of the founders of iLads with a group of other people. And my background is as an immunologist. I started at Wisconsin, did some basic medical school training at University of Illinois, and did a fellowship in transplantation immunology in Minnesota. From there, I went to the University of Texas, where I was an assistant, then associate professor of surgery and genetics. And after 5 years, I moved to a laboratory in LA, where I was running one of the largest immunology laboratories in the world at that time. It was at Bioscience Laboratories. From there, I went to a laboratory that was in Northern California that was later bought. It was a startup that was later bought by 3M, and I was with them for 5 years. And 3M, after usually 5 years, and they don't want to keep the company, they sell it. I didn't want to, that's much better. I didn't want to move to Maryland, so I bought one of the labs that I was running, which was the reference laboratory. I purchased the laboratory in 1991 from 3M. They gave me a buyout that enabled me to purchase the laboratory. It was originally for full-service immunology, but we changed the lab to be everything Lyme. And that's got me involved with Lyme disease at that time. Well, there's a ton of challenges. I mean, there's two different groups. There's the iLads groups, and you have the academic physicians, infectious disease docs, and they have a very tight definition of Lyme, although they've opened up the door quite a bit recently, but they're still about a log away. They went from 30,000 to 300,000, and if they do one more log, then I wouldn't have any problem with them, because I think about 3 million people per year is the number of people that get Lyme disease. But there's a lot of definitions. What's Lyme? Is there chronic Lyme? And I feel that there's a lot of good evidence for persistent or chronic Lyme that's been overlooked by a lot of the academic centers. And those people get better when there's good documentation that they have Lyme when they're treated with antibiotics. We've had several patients that have gone through life not really knowing what's wrong with them. Some are sick enough where they can't get out of bed. Others have been given diagnosis of ALS. And most of the cases of ALS, it is ALS. But there are some patients that when treated, their symptoms go away. That can't happen if it's really ALS. Now, we're not involved in the treatment of patients. We're there to help and support the physician in the diagnosis part of the disease. So I hear secondarily from the patients or the doctors that our testing technique has enabled the physician to go ahead, be comfortable with the treatment that they're using, because they can believe that the patient does have Lyme disease. And there's been patients that have said that IGeneX has helped save their life. And I get this multiple times a week in talking to patients and doctors. So I have to believe that we're doing what's right. We don't have a method to say what's the best antibiotic to use. In regular microbiology, you grow up the organism in a patient in a petri dish, and then you compare it against different antibiotics. It's very difficult to grow up or grow Borrelia. And even if we could grow it, couldn't we grow it in the same type of conditions that it's in the patient? When we take Borrelia and look at it against different antibiotics, all the antibiotics work. That's not the case with patients. So we need some sort of test to be able to look at the organism in the patient or in the patient's blood and to be able to treat it in a way that makes sense for the patient. We had a foundation, Turn the Corner Foundation, offered to ILADs some funds to help develop a physician program. And I was lucky. I was the treasurer of the organization at that time, so the program got dropped in my lap. So I took what I was given. I mean, I had money, and then we started looking around for doctors that would be interested in more training. We had a core group of training doctors. Many of those are still with us. And set up some information that this type of program was now available. You would follow around a doctor for 5 days, sometimes more than 1 week, and they would receive a small stipend to enable us to train the physicians. And that went along pretty well for a few years, and then money got tight, and I decided to provide a fund that would enable us to keep this service available. And that's the fund that I started this year. And there's a certain amount of money that will be available every year for physicians. When that fund gets emptied, additional money will be put in. This year, we don't have as many doctors that are coming into the fund because we want primarily MDs and DOs at this time. And each one is also given a membership in ILADS. It's paid for out of the grant. So we just need to develop this program in such a way that people know that it exists. And we're hoping that at this meeting that's coming up, they can see that this program is beneficial. They can get training following a physician that's one of the trainers. And we're hoping that this will take off. The significance of the training program. Lyme is a very difficult area to just go in because there's so many different presentations of what Lyme looks like. And the idea is by following a physician that is seeing patients over that week where the trainee is following the doctor, they're going to see all the different types of presentations of Lyme. Because that's the most difficult thing. I mean, there's so many different symptoms that can be Lyme-like. If you follow the physician, you're going to see the range of treatment and range of problems that exists in Lyme. You can't imagine just saying, well, we're going to see patients with arthritis or patients that have some mental confusion or patients that has fatigue. But when you start opening up the doors to the Lyme patients, sometimes you're going to see all those symptoms in one patient. And that's what's really difficult. And sometimes it makes it really difficult for reimbursement because everything in reimbursement is based on one problem. And that's where you have a 15, 20-minute appointment that they're going to discuss your fatigue. Well, you come in with fatigue, eye problem, joint problem, that's 3 appointments. And the Lyme doctor has to be able to sit down, interview a patient long enough. In that first interview, maybe an hour and a half, 2 hours, to try to get the concept of what's going on with this patient. It's not a disease of just onesies and twosies, and it's multiple symptoms are going on at the same time. And that's different than you see in the regular patient. Well, there's so many patients that have symptoms that you can't easily put into a box and say you have Lyme disease. You have a group of symptoms and you need to provide a way for these patients to be seen by knowledgeable doctors. And the only way you're going to get this is to try to clone the doctors you have now. And the best way to do that is to have young doctors that know medicine but can follow one of our Lyme doctors during their practice and see what they do. And that's why the program is really you're following a physician that knows Lyme, and you have to see how they can move from patient to patient, from symptom to symptom. It's not like shooting an arrow at one thing. It's many things that you're looking at the same time. And we have to provide testing that's broad enough that, yeah, you look for Lyme antibodies, but then are there markers for DNA? Are there any co-infections that are involved? Many times it's just Lyme. I say just Lyme, but just Lyme, maybe 200 different symptoms. Or there could be other organisms involved, and you have to make the distinction between whether it's Lyme plus or just Lyme with multiple symptoms. And the treatment is different for each one. And that's where the training program really looks at what the doctor's doing and to try to share that with physicians that know medicine but have never seen a Lyme patient. And then they hear a lot of horrors of dealing with Lyme patients. Most of the patients are not, it's rare where a Lyme patient is in the hospital. We try to keep them out of the hospital because that brings in other types of infections that people can get that are hospital acquired. So if we can treat the patient at home as an outpatient, we're in much better shape. And this is why the training program works so well, because it's not like a group of 40 medical students are in the room and in comes in the doctor. I mean, you're following the physician that knows how to treat Lyme from morning to night during their rotations. And you have to, it's better to have a trainee work with a doctor for a week, go back to their practice, and then come back and do it again. And the training program has to have that type of flexibility where people can get in and out of the program, because if you just give them 2 weeks of information, that's information overload. You can't do that. You have to do, 5 days is really a maximum amount that you can digest. And then there's going to be things you forget, so come back again, that makes more sense. And we want to try to provide such a program. I would like to see it progress by getting doctors in all parts of the United States. That's our first goal, is to train doctors in even areas where there's not a lot of people, because we're still seeing Lyme there. We have one physician in Montana, one physician in Utah, and the rest of the patients are being treated by nurses, and they're doing a great job, but that's a lot of responsibility and a lot of work for people that haven't had complete training. So they're learning as they go. If we could place a doctor in that area, that'd be great. So it's expanding the program, expanding, we have plenty of doctors in New York and in California. Lost the picture there, it's back.
Okay.
But in some parts of the country, we don't have anybody. And I can't believe it's because there's no Lyme there, because we see Lyme throughout the country. All the patients that I see and talk to, I just want to help them and provide help available. I mean, when someone is sick, they don't want to have to stand in line for 4 or 5 months before they can get in to see a doctor. And that's the stage we're at right now. And that's just not fair. patient should be able to see a doctor in a week or 2 weeks. That's kind of my goal. So there's a lot more doctors that we can train, and I think we're up to the ability. We have 10 trainers around the country. We're interviewing a few more potential trainers. We're interviewing some international trainers. I mean, there's a lot of Lyme going on in Australia right now. There's a lot of Lyme in Canada. And we don't really have a mechanism yet for training doctors outside the U.S. It's really hard to do it by a television screen. You need to be there. You need to see what goes on in the office. And that's important. For more information concerning the treatment program and other things that I've said, please contact ilads.org.